I think the challenge we have, though, is that people have to understand what home health care is and what it isn't. So if you go back to the 1960s and when they were pulling together the Medicare program, one of the things that they funded was home health care. But the idea back in the 60s, which hasn't really changed that much in the last, 60 years or so, is that home health care would be a bridge from being completely cared for in the hospital to be completely independent in the home. And independent in the home could be with family support. It doesn't mean you're living alone. It just means you don't need a healthcare provider to come in and take care of you. So if you think of the way home health care was designed as a bridge between complete care and independent care, then it was set up as a short-term episodic intervention to bridge that gap. So home health care was really intended that you wouldn't need the help. It would be intermittent, so you wouldn't see someone every day. You would go several times a week to help them and their family determine how to be independent in the home. You would need it for at the most 60 days. I thought that was 2 months. That would be a nice time frame.
Hello, everyone. Welcome to this podcast series where I have with me Kathy Duckett, and I'm Arvind Sarin. I'm the CEO here at Copper Digital, and we are building an amazing product for home health. And I'm so glad that Kathy, you're here. And I really am excited about sharing some of the learnings that we've discussed and just generally the opinion about home health and technology playing such an important role in this. So welcome to this podcast.
Thank you. Thank you, Arvind. I'm really excited to be here and very excited to be on this journey with you. I think it's going to change the way we do home health care documentation. So it's going to be great.
Fantastic. So great. How about we get started with learning a little bit more about you and your background. And so if you don't mind, if you could give your background and how you got started in home health, that would be a great beginning for the audience.
So I've been in home healthcare for over 30 years. And actually, my bachelor's degree had 10 weeks training in home health, which is very unusual. So you had one whole semester in home health. So I had an opportunity to work as a VNA nurse early on in my career. I got out of it. I graduated and I did my mandatory time in the hospital, and then got into home health again in Detroit. I was from Detroit originally, and I worked with a home health agency in Detroit and did that for several years, carried a bag, took care of patients. And in that time, you started with patients that were in more of challenging environments, maybe environments different than I grew up in. And you got a really good opportunity to see people in all walks of life, people who had a lot of money, people who didn't have any money, people who were just struggling to put food on the table and figuring out which meds they were going to pay for. And then people who, had got new cars every year. So it really gave me the opportunity to realize that people are people, and sick people are sick people. And that doesn't make any difference. And how people respond to illness is how they respond to illness. And my job is to help them get back to the level that they want to be in or can be in terms of their health and how to make that happen. And so that was a wonderful learning experience. And from there, I went to Los Angeles and started off again doing hospital work as you're getting to know a new area. But the hospital that I was working at was forming their own home health agency. So they took all of us that were considered the troublemakers, the ones that really wanted to sit down and talk with the patients. And they moved us all to home care, because in home care, you have to be a lot more autonomous. You have to be a critical thinker. You work autonomously because you're going into the patient's home. And so that was a great experience. And it was a teaching hospital in Los Angeles. So we got to do a lot of cutting edge home health interventions. So that was also a wonderful learning experience. And then I also had then the opportunity to do other things in home care. I was a nursing supervisor, a clinical manager. I was the director of nurses. I ended up being the regional director for Los Angeles County for a home health agency. That was a fascinating experience as well. And then I've also had the opportunity to write patient education materials, nursing education materials. And then we moved here to the Boston metro area, where I got back into home care and then became a chief clinical officer. I've had the opportunity to work with other countries that were setting up their remote patient monitoring about 15 years or so. I got much more into technology and how to use technology to improve the care that we can provide in the patient's home, and how to use technology as another tool that the home health nurse has to provide better care. So got into remote patient monitoring, got into that piece as well, and have had some wonderful opportunities through that. I was the director of advanced care at home, which meant that I was looking at their specialty programs and how to build their specialty programs for sustainability, both within the agency, but then also looking at how did the agency want to position itself a year from now, 5 years from now, to meet the changing needs of home care. And that was my job as well, to say, okay, not only how do we improve the care we're giving now, but what do we need to do to position ourselves to be viable in the next 5 years as home care needs change? And how do we do that? And how do we adapt again to the changing environment, and then also to the economically changing environment and for reimbursement and that kind of stuff? So I had the opportunity to do that. And
Wow,
yes.
that's like, this already is like touching so many different aspects within the home healthcare, like from being a clinician and actually caring for patients and understanding, their life and their experience, to all the way working with an administrator and setting the financial goals and those operational guardrails. And that's fantastic. So you have a really wide variety of experiences within home health. And that's why, I guess, fast forward, I saw you speak at National Alliance for Care at Home in NOLA, Louisiana, last year. And you talked about the future EMR and what should be some of the considerations. And I really loved what you talked about, having the perspective of a clinician also present while we're designing these AI products. And that really resonated with me. And then I spoke with you, and then we found a way to work together. And I'm so happy and glad that now it's your second week here at Copper Digital, where you are helping us as a clinical advisor and making sure that we shape the product from that right empathy for the patient, for the clinicians, for the home health agency owners, and do the right thing as we're designing this. So I'm so glad that's why that you're here. And tell me for the audience, perhaps, and I'm thinking, like, who are the people who would be interested in learning more and would be watching this series? And I feel like this would be a lot of young people who aspire to be home health agency owners, or it may be a lot of the director of nurses or administrators, and trying to find the best practices or how AI is changing the industry and how they could perhaps learn from experiences that we may be able to share. And then it could also be some of the investors who want to put in some capital in this space, and they want to understand the importance and significance of home health. Because I can tell you, I have been the more I learn about home health, I've been fascinated. And it's usually not even something super sexy that you want to, like, oh, I do home health AI agents. It's, it's supposed to be one of those, like a problem that needs to be solved, but definitely not something that is going to be attractive, like building, AI therapist, that solves everyone's problems. That's, something that attracts a lot more people. So I want to start off by saying why home health, is so important. And I've got my perspective, and, I think about it, but I'd love to learn, like, from you as well. if you feel that home health is just so important in such an important place, in the continuum of care, like, why do you feel like it's so important that we should care about putting our best people into solving this problem?
It's a great question. I think that as we're realizing, there's two different things going on. The first one is that home is the place where people want to be. We know from research studies that we've done that people get better faster when they're in their own home environment. We know that patients with dementia have less problems with dementia if they're being taken care of in their home versus if we move them to a hospital to take care of them, then they're out of that environment they know, and their confusion increases significantly, which makes them have more challenges when trying to be taken care of in that in hospital environment. We also know that hospitals are really made for us as clinicians. So we wake you up when we need to wake you up, and we, do the tests and we do all that kind of stuff. But your whole day is really surrounded by what we want you to do. So you're on our turf. The beds are not comfortable. The environment is pretty sterile. Generally, you're not in your own room. So you're sharing a room with someone you don't know, and all of their habits and family members or whatever. So it's really not a conducive environment for healing. We absolutely understand that. So we want to get people home because they are going to heal faster. They'll have less infections. Infection rate is much more decreased if you're in a home environment than if you're in a hospital environment, generally speaking. And, there's reasons you have to be in the hospital. If you're acutely sick, you need to be there. You need to be where you can get 24-hour care with the best equipment, and the experts who are available to be right there for you. So if I'm going to be really, really sick, I want to be in a hospital situation. But once I begin to recover, if possible, I'm going to want to recover at home, and I'm not alone, and outcomes are better if I do that. So we know that. But the challenge we have is that how do we deliver that care effectively? We have a limited nursing workforce in general, and we certainly have a limited nursing workforce in home care. It's for a lot of reasons. But the reality is we don't have a lot of nurses. The other reality is we haven't figured out another way to see patients except one patient at a time. We go to their home. So we have to recognize that we're limited by the number of patients we can see, by how long it takes to get to their home, and then the amount of time that we spend in their home. Documentation in home care is a big challenge. And so if we're going to be spending time in the home, we want to limit the amount of time we're doing documentation and increase the time we're actually taking care of the patient. So we know that people get better care if they're at home. We know that ostensibly we want the powers that be want to move care to the home. And if we're going to be doing that, then we have to figure out a much better way to deliver that care in the home. And documentation, as we talked about before, is a significant dissatisfier for clinicians in home care.
Totally. Right. And I think even the cost, right? Mm-hmm. Some statistic that I heard was every day a patient's at the hospital is $3,100.
Right.
And for at home, it's $1,100.
Sure.
Or so. Yeah, something like
significantly less. And why? Because you're not paying for the building. When you have a hospital, you have to pay for the 24-hour nursing care, but you also pay for housekeeping, and you also pay for the kitchens, and you also pay for support staff and the lab staff and all those people that I may not be needing at that moment on that day, but it's all to help keep the building running. Right.
Totally.
So,
especially with low acuity, I mean, you don't need as much care or as many people just on standby,
right,
all the time. So
but it's still more expensive. So you're right. If I can take you home, and that's actually the hospital at home that's the philosophy of hospital at home. So one of the other things we're looking at is, are there patients that could be hospitalized, but they have a lower acuity diagnosis? And so if we gave them enough support, could they be managed in home? And the answer is yes, we can. We can manage people more effectively in a home environment for less money than it costs to take care of them in the hospital, but still more money than it takes to do a typical home health patient, a traditional home health patient like have been taking care of for a million years, right? And it
Absolutely.
has to do with the acuity level and
Makes sense.
the needs in the home. So
And I think you're right. Like it really, the hospital at home is a trend that has been exponentially growing over the last, couple of years for sure. I've been watching it in my research, and a lot of new startups coming up in that and remote patient monitoring. And so these are some of the trends that we see in home health. But kind of taking us back to the original, like why it's so important for, like, even let's say the country to get a handle of the home health and drive innovation in home health. And I've reflected on this a little bit, and I feel like, it's almost like you tell about a country by the way you care for your elderly. Like you see that, oh, America is amazing because you care for the elderly people. I mean, what else is the measure, right? If you can't treat the elderly with respect, with care, with dignity, with providing them everything that they need. I mean, and it's such an important fact. It gives me goosebumps. And of course, like, I the most I love anybody in this entire world is my parents. And now they're getting older, and I know that at times my dad, I have to repeat things, and I joke with him and I say, "Mom, you tell Dad." And so I know that it's going to be very important in their older age to have the right care available. And this is what I feel like makes home health like so important as well. And I also feel like home health is a place where, from home health you can go sort of, it's a place where you get triage to see if you need to go perhaps, at a sniff, at an LTAC, or like if acuity is higher, then of course hospital. And then if you are, let's say, suffering from something and you need palliative care or hospice, then you can, you have the option to go downstream as well. So that's why it's the entire continuum that I didn't understand earlier, but now after attending all these conferences and talking to people with that background, I just really am fascinated with overall, like, okay, where home health sits and the understanding that I've developed. So that was like really, really fascinating. And that's why I felt like it's an important problem to solve, because it provides better access to everyone as well, because otherwise you have, like, you're not managing the healthcare costs. And then of course with the shortage of nurses as well, I think, like, everyone getting the care that is appropriate according to the acuity is extremely important for having a balanced budget on healthcare spending. And as a country, we spend the most amount of money. So, yeah.
I think the challenge we have, though, is that people have to understand what home health care is and what it isn't. So if you go back to the 1960s and when they were pulling together the Medicare program, one of the things that they funded was home health care. But the idea back in the 60s, which hasn't really changed that much in the last, 60 years or so, is that home health care would be a bridge from being completely cared for in the hospital to be completely independent in the home. And independent in the home could be with family support. It doesn't mean you're living alone. It just means you don't need a healthcare provider to come in and take care of you. So if you think of the way home health care was designed as a bridge between complete care and independent care, then it was set up as a short-term, episodic intervention to bridge that gap.
Mm.
So home health care was really intended that you wouldn't need the help. It would be intermittent. So you wouldn't see someone every day. You would go several times a week to help them and their family determine how to be independent in the home. You would need it for at the most 60 days. They thought that was 2 months. That would be a nice time frame. And the idea really was, how do you teach the family, or the family and the patient, or the patient, depending on who's living in the home, what they need to do in order to be independent in their care in their home environment. And when you were talking about going to LTACs or going to SNFs, sometimes when we walk into the home environment, we say, there's no family. There's no one to take care of the patient. Therefore, the home is not a safe environment for the patient to be in. Now, the patient may have come from the home to the hospital, but when we look at what they're going home to, we say, no, it's not the right place. And it may not be the right place to recover. And so they may really need to go to rehab in an inpatient after that stroke, because there's really no one to take care of them at home, or their elderly spouse who really can't do it. The other thing that could happen is that we could go in the home and say, yes, the family and the patient, with maybe some home modifications, could be independent. Or sometimes it's just a matter of they're going home to recover, and we need to get them to the point where they can then go to outpatient cardiac rehab or outpatient PT after a hip or a knee or something like that. So the thing to remember is that it's intermittent care. It's a finite and predictable ending, which means when we walk in the door, we have to figure out, when are we going to stop taking care of you? And that's a really big misconception, because when people get discharged, the discharge planner says, now home health will be there to take care of you. And it's like they want to show us to our spare bedroom, right? Because they're thinking, oh, I'm going to get someone to take care of me. And, oh, and while you're here, would you clean the house? And while you're here, would you make the meals? And and the answer is no, that's not what it's for. That's not what it was set up for. That's not what the government pays us to do. So, or the insurance companies pay us to do. Then there's home care, and home care is generally either non-clinical care, like a person to help you with bathing or housekeeping, or it's shift care. So if you really need a nurse, an LPN or an RN for 4 hours or 8 hours at a time, then that generally isn't covered by most insurance. And so you then would have to pay for that privately. So I think that one of the challenges is recognize that when people use the term home health, they put it in this big umbrella term that includes home care. But when you look at what the insurance companies call home health, or when you look at what the Center for Medicare and Medicaid Services, CMS, looks at when they talk about the home health benefit, it's that finite, predictable, short-term ending. Let's get you independent so that you can be independent and living your best life at home, or let's get you the resources you need so that you can either live at home or be in the right place. So if it's end of life care, then home health care may be the people that walk in. I may walk in and realize that what you really need is hospice. And because you're on Medicare, I'm going to have you use that hospice benefit that Medicare patients get. And now you're going to be under that service, which is a completely different type of care delivery than home health care. Because in hospice, as we know, you're expected to have hospice care until you pass away. Or 6 months. And many times, not many times, but frequently, you'll have patients that have reaching that 6 month and they haven't passed away. And so what we say is, you're graduating from hospice. We thought no one knows except God when you're going to go, right? So we, the physicians, the nurses, we take our best guess, and usually we're right. But if we're not, then you can graduate from hospice, and then you could go back to home care, because now you're not in that hospice need.
Right? Oh, I didn't know that's also possible. Okay, so you could come back from hospice to
home care,
living independently, and just get a little bit of.
Yep.
Got it.
Yeah, you can absolutely do that. We call it graduating, and And when I was running a hospice along with a home care agency, we would have patients that would graduate a couple different times. They would think, okay, this is it. And we're going to put hospice in. And 6 months later, you're doing great. So, we're going to stop the hospice benefit because that's the way the benefit's written. So I think that it's important for people to understand why home care is important, but also the limitations in home care and not home care, the limitations in home health care, and work within those. So we recognize what we're actually trying to do and why our goal is to make you independent. Because that's our mandate. That's why we're in your home. We're in your home to help you become independent in your care, or help your family members become independent in your care. So that's why.
And I think this is such an important distinction. And you're right. Like, a lot of the people not from the industry definitely don't understand the distinction between home health and home care. But you would be so surprised that even at times, people sometimes involved with the industry, but not so much in the industry, they don't understand. And there's a funny story there. I was at this conference and somebody came in with this entire product, a Silicon Valley company. I don't want to name anybody, but he was a great communicator, and he spoke, and he came up with this AI agent that would help you help home health, because it was just a home health and hospice conference, and it would help you in closing like the sale, if you will, like in getting more patients. It would, and he created this agent, but somebody asked, like, okay, in home health, the referrals come from post-acute and they come in as a fax. So what do you mean? How are you going to help me handle those calls or do follow-ups? You don't really need to follow up. You just accept the patient and you go do the start of care. So it's funny. So that's why I feel like not everybody understands, what is the difference. And so thank you for explaining that. Even I didn't understand that, like I said, from hospice, you could go back. And I've been really been doing a lot of research and speaking to people every day, about this space. And what I used to think was, for hospice, it's 6 months as an approximate time. But if average time for a hospice is the patients only stay for 7 or 8 days, that means they're not getting prescribed hospice, at the right time, and that's incorrect. Or if they go beyond the 6 months, that means, okay, you were prescribed too quickly, or maybe you're lucky. That, could be anything. So I'd like to know, in home health, at times when we have the assessment done, then we're trying to understand the level of independence of the patient. However, it's really home care where we provide them support with ADLs. So maybe can you try to explain why we have to then answer those questions during the initial skilled nursing eval when we do the start of care?
Sure. Because what we're trying to do is we're trying to find a baseline for the patient's ability to do things independently, so we can develop a care plan to help them get them to the next level. So if you come home from the hospital and you need help walking, getting in and out of bed, right? So in order to understand in order to know that I need to put a physical therapy in the home, I need to know what you can and can't do. Because if I come to your house and, you're just like, hey, and you open the door and you're walking really well and everything, then I think, oh, and then I go and I do the assessment and I say, show me how you get from a sitting to a standing, and you demonstrate that you're independent. I'm not going to put physical therapy in the home. Even if the referral came in with a physical therapy eval, I would then call back to the physician and say, when I assess the patient in their home environment, this is what they could do. Is there something I'm missing? Because it looks like they don't need those therapy services. And the same thing with occupational therapy. Also, one of the things that home health provides is ADL care, is bathing assistance from a temporary basis. Because remember, the thinking is you only have 30 to 60 days, but you come home from the hospital. And generally when people come home from the hospital, they're deconditioned. They've been laying around, they've just had major surgery or been very, very sick, and they just can't do what they normally used to be able to do. So maybe you really do need someone to help you with your bath for the first couple weeks that you're home. I will put a home health aide in your home to help you with your bath. That's different than from now on, you're going to need someone 4 hours a day, 2 to 4 hours a day to help you with your bath. Because remember, if home health is an intermittent 30 to 60 day need, and sometimes we go longer than 60 days, we recert patients because they're not quite where they need to be yet. But the idea being that they're going to be very short term. If I come in and and you don't have that home care, personal care aid, I could put the home health aid in and then realize that you're not going to get to a point where you can bathe independently. I'm going to be talking with you. I'm going to be talking with your caregivers to see how are you going to get that help that you need on an ongoing basis. But in order to do that, I have to establish a baseline. And in order to establish a baseline, I need to ask you all those questions. And I also need to watch you. So I may say, do you have any challenges with going from a sitting to a standing position? And you may say, no, I'm fine. I can do that independently. And I'll say, okay, well, show me. And then when you struggle to get up, then I realize that you can't. And then depending on how much you struggle, that's how I grade you, even though it's not really grading. It really is assessing what level you're really at. In addition to that, reimbursement is based on how sick is the patient. That's so under Medicare, the sicker you are, the more we get paid. And we don't want to falsify it anyway. We don't want to say you're not as sick as you are, and then we don't get reimbursed at the appropriate amount. And we certainly don't want to say that you are sicker so we get reimbursed more. So we really want to do it accurately so we get paid the right money that we need to get paid in order to give the right care that we need to give. So
Makes sense.
There's a clinical assessment, there's a clinical reason, there's also a financial reason.
Got it. Now, 2 questions on that, and this is very interesting. So then essentially, hospice generally should be 6 months, home health generally should be 2 months, and home care should be long term.
Generally speaking, if you're going to need that, you're going to need someone to help you in your home for a much longer period of time. Having said that, if I come into your home and you have that need right off the bat, and your family says, well, I'm not going to be here 8 hours a day with mom to do whatever. Then it becomes a matter of is she safe in her home? And if she's not safe in her home, then she has to have that provided. And then we're talking about who pays for it. And right. And the federal government doesn't at this point. Federal government's not going to pay for that, but Medicaid will. The state programs will, depending on the patient's needs and the patient's financial status. And it help in the home. So, who pays for it is a really tricky question or difficult question. And sometimes that makes a difference. Can people live in their home or not? That's one of the things you learned, right? If you have a ton of money and can pay privately for 24-hour care, then you can stay in your home, even if you're really debilitated, because you have the care you need. And either you're paying for it or your family members are paying for it. If you need a high level of care, but you don't meet the criteria to have the state pay for it, your family can't afford it, you can't afford it, you may end up being in a nursing home or someplace else because that personal care need is so high and you're not going to get back to the point where you can do it yourself. And there's nobody to help you and you don't have the money to pay for it.
Got it. And
that's the reality, right? That's the reality of home care in the United States. That's not a challenge in other parts of the world, but it's definitely a challenge because of the way we pay for home care here.
So then if they don't qualify for Medicaid and they cannot take care of themselves, then they go to an ALF, like an assisted living facility, or
could be, or a skilled nursing facility or a long-term care facility.
Wouldn't skilled nursing facility only be if they require skilled care? If they're coming from home care, that means they just need the ADL support.
Well, it depends. If you have something where the person requires some medication or some skilled nursing intervention, what I'm going to do is I'm going to teach you how to give it to your mom. right? So let's say I'm talking to you, and
Right.
you're there with your mom and dad, and your mom is sick, and she needs to take her pills several times a day, and she can't do it, and a medication dispenser is not going to work for you. Or let's say she's got some IV antibiotic, even if it's a short-term IV antibiotic, right? And it needs to go 3 times a day, but you can't be there to support her and do that. Then, and she can't do it and your dad can't do it, then maybe home care is not the right way, because we need to be able to teach someone how to provide the care, how to do the things.
Got it.
So it might
Got
be skilled. Could be, we try not to do that though. In home care, we try and figure out if she came home with dressing changes twice a day, nobody in the home is able to do that. Is there some way that we can work with a wound care specialist and move it to once a day? And then we could come once a day to change that dressing, because that's one of the exceptions to the daily limit. So we try and do that. If it's supposed to be a 3-time-a-day IV antibiotic, can we work with a physician and change the antibiotic, change the dosage, change something so that it will fit, so that we can take care of it? Because we really want to keep you in your home. We really want to figure out how to do that. So, but you're right in terms of if the patient has personal care needs, ADL needs, that kind of stuff, then they could go to a long-term care facility. They could go to an ALF would probably be too high. I don't think they would bathe them every day at an ALF.
Okay.
Right. So it'd be more of a long-term care facility, and they might have to go there because they might have to move there because they just can't be safe in their home. Because that's the key. Are they safe to live in their home? And if they're
Got
not
it.
safe for whatever reason, then home is not the right place for them to be.
And long-term care facility, is there such a thing in the sense that I've only heard of SNFs, LTACs, and those are for more acute, the long-term acute care hospital, and then the ALFs are the assisted living facility, then and rehabilitation centers. But is there something like a long-term care facility also?
So the long-term, well, that's the LTAC, that is an LTAC is a long-term care.
Okay, but I thought that was for more acute patients. Got it. You can
You
have,
do it different ways, right? So, but generally, if you have a surgery or have something happen, then you could go to, and you can't go home for whatever reason, then you'll go to an LTAC. But you can go to an LTAC to do that recovery, even if it's 6 months. And now you've gotten to a point where you can go back home because now you're more independent. So can you move back home? And a lot of skilled nursing facilities are becoming rehab, short-term rehab, long-term rehab, long-term care type stuff. So
understood.
Kind of morphing depending on what we need.
And I think different states may have different rules and regulations as well to support opening of more ALFs versus SNFs versus, I think there can be.
Right.
So another thing you mentioned, which was very interesting, and I talk to my engineering team all the time about this and trying to figure out sort of the documentation problem. But I mean, so you mentioned that it is in the best interest to code accurately. I mean, of course, morally it's the right thing to do. You don't want to be lying as, of course, because that could have different consequences. But if you could think like, oh, you know what? I really want to rate the abilities of the patient to the lowest possible at the beginning and then the highest possible in the end when I discharge, then like, I understand why that's wrong, but then what else is wrong about it? Like, except for it being actually wrong, like why would a nurse not do that and say that, hey, I'm only like maximizing the reimbursement, so why not? It's not like I'm affecting the patient, right? I mean, anyways, CMS had all these cuts and, we don't get paid as much and there's LUPA. So why can't I just all the time assess the patient lowest possible and then the highest possible at discharge? I mean, just wondering.
That's a really great question. And I think the really, really, really simple answer is it's against the it's against the law. You're lying. I mean, but again, I think that if you're saying this is where the patient's really at, and the challenge we have with nurses is that nurses always tend to think that patients are better than they are. So it's like when you have a physical therapist and a nurse evaluate the same patient, invariably the physical therapist will say the patient has less ambulation ability, less range of motion and everything than the nurse will, because the nurse is looking at the patient differently than the physical therapist, right? That's the therapist's job, right? To say they're at a 45-degree angle, a 30-degree angle or whatever, and really catch those nuances. And nurses tend to not do that. And so when you really talk to the nurse and say, well, you said they could walk 30 feet. Did you really walk them 30 feet? And did they have no short of breath? And when you start really going, well, they were like, no, well, they had some. Well, then you should say they had some, right? So I think that it really, one of the reasons we teach our clinicians to mark them at the lowest level they are is because that tends to be actually the more accurate marking. They really are short of breath when they start. If you're sitting there and you start to talk to me and you start getting short of breath, then you really are short of breath at rest. I mean, you haven't really done anything. All you did was start to talk. So you are short of breath at rest. But they'll say, well, no, when they're sitting really quietly, they're not. Right. But they really haven't moved and now they're short of breath. So I think that's one thing. And then the other thing is at the end, you really do want to demonstrate how far they've come. Now, if they haven't come anywhere, if you got them and they were short of breath at rest and you leave them and they're short of breath at rest, then did they improve under your care? The answer is no, they didn't, but maybe they didn't. So honesty is where you really want to go. But again, I think the other thing is because we don't accurately assess them on admission, then when we get to discharge, it looks like we didn't do anything at all. And we really did a lot. But generally, we're not doing a good assessment on admission. Generally, we're over assessing where the patient is really at. So what we work really hard with the clinician is to have them really think through the question, because the OASIS developers have had very specific parameters for how you would answer each question. And so one of the challenges we have is to teach home health nurses what those OASIS developers were thinking and continue to think in terms of how do you accurately answer the question. And you have to think not what would I think, but what would the OASIS developers think about that.
Yeah,
right.
Absolutely.
And I'm sorry, but that's the key. The key is really teaching people, what do they think? How does OASIS think about this question? And it varies. Some of the questions are in the last 14 days. Some of the questions are at this moment. Some of these questions are usually. And so again, you have to really parse that out and understand that in order to do an accurate assessment.
Totally. And kind of circling back on that original, question on assessment, like what prevents, like how is it also, besides being, illegal, why else is it not in the best interest? I feel like, maybe it is in the best interest from a reimbursement standpoint, but I don't think it's in the best interest. Of course it's a lie, but it's also, I feel like you're not really involved in the entire patient journey. So that it carries some risk that you're misdiagnosing and writing that documentation. Because I feel like, when I talked to Michael, and as you know, Michael was one of those people hired by CMS. And then later on, he served in finding, working with the CMS to find places where there was fraud and abuse. Mm-hmm. And so that's why he brings that unique perspective as well in our team. But the point being, like, I think if you diagnose, if you do the assessment inaccurately for, let's say, some greed of higher reimbursement, then you're really putting the patient at risk, because next time when the next nurse may arrive, the PT may arrive, or the aide may arrive, they would assume things that are not actually true. So, yeah. And
Well,
plus,
but
yeah,
I think that I can understand your point, and fraud and abuse is a problem. And that is definitely where Michael's head was at, right? People do lie. I mean, they do lie, and there are bad actors. There are bad actors in every business. There are bad actors. We know there are bad actors in physicians and nursing practices. I mean, we know that. But the majority of the time, the challenge with accurate coding on admission, it's not coding, accurate assessment on admission, is the fact that it goes the opposite way. So if I, as a nurse, say the patient's not very sick, right? So let's get the money out of it, right? And then the PT comes in and documents the patient's real accurate level, and they appear much sicker. Then the question is, what happened? How did the patient get worse in the 4 days? Or did you, the nurse, inaccurately assess the patient? And the opposite is true. If I say the patient's really sick, and then 4 days later, and the patient's up and running around, then and the PT documents that because they're documenting accurately, then it's like somebody's not right. Right. And so when you're looking at assessment for fraud and abuse, you look at those things that don't match. You look at why would they be really high on one end and why would they not be high on the other end? And sometimes it's fraud. I mean, sometimes it's really true.
uploading, yeah, sometimes.
Sometimes they just, they're maximizing reimbursement. Right. And that's true. But my experience is that, well, if I'm going to be involved in an agency, we're not doing fraud and abuse. So first of all, so let's just start with that. So,
Right.
So that's not going to be happening on my watch. So what I found more often is that the nurses just really didn't know how to assess the patient accurately. And,
or they were in a rush,
because
they had to care for other patients, not because,
the OASIS, the start of care assessment is huge. And so it's really easy to say one thing on one section and say another thing in another section. And then unless you have some sort of check and balance where somebody calls you on it and go, wait a minute, you said this over here and you said that over there, they don't match what's going on with the patient. And then have the nurse be able to say, oh, okay, well, the reality is this, and then correct that. Then without that, then you again have errors, and it looks like you're committing fraud when really you're just not being accurate. And I think that what I have found in my career is not that the nurses meant to commit fraud. They just were either rushing through because they were trying to get everything done in a really fast manner so they could do what they needed to do with the patient, or they just didn't understand it.
I think there's another reason as well. See, nurses don't get paid on the basis of reimbursement anyways. What is the incentive to commit any fraud? Like to make their bosses more money? Like, no.
No. Right. That's really not generally not a yes. It's really not something that most nurses want to do. And I have learned over the years to not jump to committing, fraud or lying or something. Now there are some nurses that do not great things. And have I had to report them to the board? Yes, because they didn't see patients and bad things happen, right? There are bad actors, like I said, bad actors. But most of the time when I would dig right into it, I'd say they didn't understand the parameters of the question. They were thinking what the patient did before they left the hospital, and this is asking what the patient can do today, right? Or they were just answering the questions quickly, and they didn't have an opportunity to think. I mean, there's 200 questions, right? So they didn't put it all together in terms of how could you say the patient has this respiratory status and yet say they can walk 30 feet without, they can't. I mean, so where's the disconnect? So.
Totally. And I think that leads us to something that we talk about a lot, the OASIS questions and the OASIS document. So everybody, so OASIS, for anyone who doesn't know, outcome assessment information set. And I forget, you can correct me there, but maybe it came out in the 90s, maybe 95-ish initially.
Somewhere, yeah, and then I think it was in the 90s.
Right.
Michael would know.
and then so then there's OASIS, and you fill out the entire paperwork, and that has a lot of different questions. And the questions there are some that are administrative questions, like who's your emergency contact, who's taking care, what's the living situation, all that stuff. And then there are questions like the GG items we call, that are the functional abilities, like what can you wear the shirt and the socks and this and that. So those questions. But really, I think there are a lot of other questions as well that require you to do some clinical observation and say, oh, because the patient has to take these 4 steps to get to their home, they're homebound, and it's not safe for them to go to a facility to get seen. That's why they require this. And there are many other factors as well. And yes, it's a 23-page document, and there may be different versions, and it may be longer as well. But I guess that document is just so central, just so important, is what I've realized over the last 18 months of me learning more and more about this field. I mean, that document is everything, because, and here's why I say that document's everything. Based on that document, you have your surveys as well, your CMS survey, the rating of your agency depends on that. If you delayed transmitting that document to the CMS, again, you are dinged for that on the ratings. Then that is the document, that eval decides what is the plan of care, what care you're going to get and how you would become from your current abilities to where we consider you independent, the abilities that you could achieve. So, I mean, there is nothing more important than the OASIS document, and especially at the start of care, because that's going to determine everything. That's also going to determine your reimbursement as well. So I get really passionate about OASIS document, and I know there are a lot of companies that just do this. I mean, I know Linda from OASIS Answers, and then other smaller offshore companies as well. They're called OASIS, Gravita OASIS Review. People have OASIS in the company names. They have services where they would double check and do QAs and support in this documentation. So it's obviously one of the most important documents. And yes, it takes time, 2 to 3 hours for the clinician to fill it out. So, and that's, as you know, that's the problem that we're solving at Copper Digital by building Copper AI. And I'm very passionate about this. And we continue to learn more by having those experiences and working with the clinicians and seeing the kind of documentation and the clinician notes. And I think that's an area where in our next podcast, I'd like to go in more details and talk about where do those 150 questions on OASIS come from? Where are those answers? And we've got some really, seemingly great ideas, but we don't know how practical some of that might be, including getting 60% of the information from H&P, from health and physical, that's on the referral document. Why does the clinician have to fill in those types of details that are already there in the system? And then AI being able to do the pre-admissions call and verifying certain information. I mean, that just finishes all the administrative items, or sending a link to them, kind of like how we get in the primary care. I mean, I get in the Texas Health Resources app the information that I have to fill in before my regular PCP visit. So why can't home health that has lower acuity have some sort of a similar, secure, HIPAA-compliant process where they get a text message or the daughter gets the text message, and we are able to securely have them tap away all the information in the emergency contact and whatever the administrative information is. And then after the visit, the clinician just gives the notes, just assesses the situation and says, here's my assessment for the mental, for mood, for this, for that, just those clinical observations she's able to give. And then what we have is, being able to go in and letting AI figure everything out and answer all the questions and seeing, all right, these 5 questions I still need the clinician to answer, because on the basis of the clinical notes, on the basis of the pre-admission call by AI and the HNP, we're not able to answer those. How do we answer those? And that's what's answered by the nurse in any form. And then the final QA review happens that also checks for other things that are very, very important that may have been missed, including the F2F or including, anything else that may be needed. So that's what we're trying to, bring, as you know, and that's what we talk about. And I think that's where we could get in greater details about understanding that process and the importance and the different actors that play an important role within home health, from patients to the clinicians to the home health agency owners, and how our Copper AI way just creates a win-win-win, but also has what CMS wants it to be, like based on the value-based purchasing that we could talk about next time. I mean, these are the kinds of elements that CMS also wants in the care that technology can enable. So super passionate about it. Thank you so much, Kathy, for your great insights and from your experience. I really appreciate it and can't wait to have our next discussion where we get in more details on this and share our insights and experiences and the technology perspective with everyone who wants to play a role in home health.
Thank you. Thank you for inviting me here. It's great.
Awesome. Thank you, Kathy. Talk to you later.
Bye-bye.
Bye.